Welcome to today's webinar, Opportunities and Challenges for Rural Hospitals, brought to you by NCSL. It is now my pleasure to turn the floor over to Samantha Scotti. The floor is yours.
Thank you, Angelica. Good morning, everyone. My name is Samantha Scotti, and I am a research analyst with the NCSL Health Program. And on behalf of the National Conference of State Legislatures, I'd like to welcome you all to today's webinar, Opportunities and Challenges for Rural Hospitals. I'd like to remind participants that NCSL is a bipartisan organization of state legislatures, and NCSL advocates for the interests of states and provides policymakers the opportunity to exchange ideas. This webinar is a platform for information exchange, and we do encourage a robust Q&A at the conclusion of this presentation, and remind participants that they can ask questions at any time during their webinar by entering in questions into the chat box on the bottom left hand of their screen. Also, today's webinar will be available on the NCSL website as a video archive. And before I introduce today's fantastic speakers, I'd like to thank the Health Resources and Services Administration for their support of today's webinar. NCSL has increasingly heard from policymakers investigating innovative ways to improve access to health for rural America. Healthcare delivery for rural residents faces a number of obstacles that create unique challenges for rural America and rural hospitals in particular. Our first presenter today is Dr. George Pink. Dr. Pink is Deputy Director for the North Carolina Rural Health Program in the Shepp Center for Health Services Research and Humana Distinguished Professor in the Department of Health Policy and Management, both at the University of North Carolina at Chapel Hill. Dr. Pink spent 10 years in health services management, planning, and consulting, and in the past 25 years, he has served on more than 100 boards and committees of hospitals and other healthcare organizations. He has written more than 70 peer-reviewed articles and has made more than 200 presentations in 10 countries. Our next presenter today will be Charles Owens. In 2015, he received direct appointment as Clinical Associate Professor for Georgia Southern University College of Public Health and the Director of the Center for Public Health Practice and Research. Additionally, Mr. Owens serves as adjunct faculty for Mercer University School of Medicine's Masters of Public Health, as well as contractor for the Georgia Department of Community Health State Office of Rural Health, supporting the Rural Hospital Stabilization Pilot. Prior to joining Georgia Southern University, Mr. Owens served as the Executive Director of the Georgia Department of Community Health State Office of Rural Health and Primary Care. Finally, we will hear from Dan Dirksen. Daniel is the Walter H. Pierce Endowed Chair and Director of the University of Arizona Center for Rural Health and Professor in the Public Health Policy and Management Program. As AZCRH Director, he oversees the State Office of Rural Health, the Rural Hospital Flexibility Program, the Small Rural Hospital Improvement Program, and the AZCRH Navigator Consortium. After graduating from the University of Arizona College of Medicine in 1984, Dr. Dirksen completed his family medicine residency at the University of New Mexico, where he worked as a faculty member for 25 years. Dr. Pink, I'll now turn it over to you.
Thank you very much, Samantha. It's a great pleasure to join you on your webinar today. I'm going to be talking about a couple of studies that we've been actively involved in for the last couple of years looking at rural hospital closures. The first study was published last year in the Journal of Rural Health, where we took an initial look at the rising rate of hospital closures. So I'm just going to give you some background information because I realize that many people on the audience may not be familiar with the prevalence and the causation of what this phenomenon, which is happening across rural America right now. What is a hospital closure? So this sounds like a trivial question, but in fact, we found that when we first started the study, it was actually very difficult because many of these hospitals go through different kinds of spirals. Where they're open for a few months, then they close, then they open, then they close. That makes it difficult to identify exactly when a hospital is closed or not. Some of these have no media coverage. Because it's a non-event in the community, it's part of a system reconfiguration. We've had some hospitals where the ER stays open, but the inpatient facility closes and vice versa, and all kinds of different permutations. So for this study, we essentially define closure as permanent cessation of acute inpatient care. So they are losing their inpatient beds, they close them, or the hospital facility closes as a result. Where have they happened? This is a map that was updated last week, so it is up to date. In the last 10 years, between 2005 and 2016, and in fact up to last week, 118 rural hospitals have closed across the United States. You can see by the map that the vast majority of the hospital closures have been in the south region of the United States, particularly in Texas, Oklahoma, Georgia, Tennessee, those states as well. When did they close? This shows the number of closures per year since 2005. You might notice that the bar on the far right for 2016 is a little different size and color than the other bars. That's because I have to update, I have to move the bar up on an average of once a week. We've had 13 closures in 2016 so far. I wouldn't be surprised if we hit 25 or 26 closures in 2016. But the most noticeable is the trend since 2010. It has been constantly upward, and it seems to be no end in sight to the closures that are happening. What kinds of hospitals have closed? We use the Federal Office of Rural Health policy definitions of rural. So metro means the metro is an urban area, micro is sort of halfway between urban and rural, and then neither is the truly rural area. So half of all these closures are happening in fairly relatively isolated rural areas. And by far, most of the hospitals that have closed are not government owned. This is a simple graph that it looks simple, but in fact it was a very complicated a bit of analysis to put together. So what this means is it's the driving distance to the nearest hospital. So suppose you live opposite a hospital, your hospital closes, how far will you have to drive to the next closest hospital for you to access? And so what this shows is that there are quite a few hospitals that people now have to drive 10 or fewer miles. But the substantial majority of people are driving 15 to 30 miles further to access inpatient care. That doesn't sound like much, perhaps, to some people, but when you're dealing with a population that's highly skewed towards Medicare and Medicaid, transportation is a big issue for a lot of the people, particularly the elderly and the people who are confined to wheelchairs and so on. There's actually one hospital that's not graphed, and that's Nye Regional in Nevada, which has actually got now, the residents of that community now have to drive 114 miles to access another hospital. Why are these hospitals closing? Again, there is no secondary database that we can access to find out these kinds of things, so we've actually had to scour the news media, talk to local community folks to find out why. And essentially, we categorize these as sort of three broad buckets of factors. Market factors, small declining populations, high rates of employment and uninsured patients, much higher proportions of Medicare and Medicaid patients. In terms of hospital factors, they're low daily census, trouble getting physicians to cover the emergency department, old, deteriorating facilities, and in a few cases, some fraud and patient safety concerns. But by far the most common reasons are the financial factors. These are hospitals that typically have had financial problems for a long period of time, as represented in charity care and bad debt levels. Some have overwhelming amounts of debt and insufficient cash flow to make their payments and to cover their current liabilities, and negative profitability, again, typically over a long period of time. So in the just some more detail about that, we looked at the hospital financial performance in the year before they actually closed. Almost all of them were unprofitable, had very low levels of current assets, and had difficulties servicing their debt. They typically had 150 FTEs or less, a $10 million in salary expense, and 30%, which is a relatively low occupancy rate. They had no net income and net assets, meaning that their net worth was close to zero or negative. And interestingly enough, most had already closed obstetrics. Many rural hospitals have been closing obstetrics in the last decade in order to, as a strategy, financial survival strategy. In most of the cases of the hospitals that closed, this didn't work. So to summarize, most have been in the south. The annual number of closures is increasing. Most are critical access hospitals, PPS hospitals. We haven't seen that many Medicare-dependent or sole community hospitals closed yet. Most are in states that have not expanded Medicaid. Most of the patients that have been affected are traveling between 5 and 30 miles more to access inpatient care, and most closed because of financial problems. The next study, just to quickly complete my talk, is to compare a study that we've just done looking at closed rural hospitals. So we looked at the actual hospitals themselves that closed. We divided them into 3 categories, those that are closed, then morphed into something else, and then those that were abandoned. Abandoned means that they are no longer providing any health care services at all. In other words, one, for example, is an office building now, one is a parking lot, one has been turned into a condo, those kinds of things. And I guess the finding that concerned us the most, this is looking at the community characteristics of the hospitals that closed. And you can see that the hospitals with abandoned hospitals, communities with abandoned hospitals, that is, the hospitals not providing any more health care at all, the overwhelming the difference between the percent of the community that's black and non-white. So we have great concerns that the rural hospital closures that have happened to date are exacerbating or could be exacerbating some disparities in access faced by minority populations. So just to conclude, abandoned rural hospitals serve markets with much higher proportion of non-whites and blacks, and were located farther away from other hospitals. As well, we found that a lot of survey respondents that we talked to found that the increased travel distances was a real risk to the health care of those communities. And to summarize then, the impact of the closures, there's limited evidence about health outcomes. In other words, just because the hospital closes, does that actually affect the health of the community? There are a few studies, but the magnitude has been mixed. The most recent study was the Joint et al. Study in the JAMA, which found no effect, but that was mostly on urban hospitals. There's a lot of more evidence about the economic cost because the hospitals is usually one of the top 2 employers in small towns. We found as well that when the hospital closes, often the healthcare infrastructure leaves, a lot of physicians, the other providers in the community. And then there was one study from 10 years ago showing that a $1,300 drop in per capita income. And then finally, some emergency evidence about health disparities and how that might be exacerbated by hospital closures. If you're interested in actually learning more about the hospitals that have closed in the last decade, we have a website which has a map where you can download data if you want, and shows you on the map all the locations and identifying data about the hospitals that have closed. This is some of the places that are supporting our work, particularly the Federal Office of Rural Health Policy, and this is my team. So I'm trying to be expeditious, Samantha, because I'm going to conclude by saying a sentence that you don't often hear 2 phrases in the same one. I'm a university professor, and I have been brief. Thank you.
Thank you, Dr. Pink, for that presentation. And next, we will hear from Charles about some experiences in Georgia.
Great. Thank you, Samantha. I appreciate that. Just as Dr. Pink alluded to, the Southeast has a huge number of communities that have experienced hospital closure. And as a resident of Georgia, and in particular rural Georgia, living in Crisp County, we see that all around. So if you could click to the next slide. In April of 2014, Governor Deal heard loud and clear from the residents of Georgia how rural hospitals are struggling. And so he came out and formed a committee and appointed several of us, I guess 16, to a committee for us to look at opportunities to help stabilize our rural hospitals. And one of the first things was to look at a freestanding emergency department. Because when you talk to rural communities about their hospitals, they immediately cling to their emergency department and say how important it is to their community. And so with that, we evaluated the viability of that. We, Commissioner Reese and the Department of Community Health led the effort to establish rules within the hospital regulations. And when we did that, we had Drafton and Tucker, a Georgia CPA firm, evaluate the viability of a freestanding rural emergency room, and quickly realized that looking at Georgia demographics and payer mix, that was non-sustainable. Staffed with a physician, based on current volumes and current utilization, it looked like about $1.25 million loss. If staffed with a PA or a nurse practitioner, it could drop as low as $750,000. We assumed that outpatient diagnostics would remain consistent because there was no control for how that would change, and I think we all could agree that that would probably decline with the hospitals losing its inpatient beds. So we met for several months. We were a very diverse group. There were a few of us from state government, but there were many from rural hospitals, rural communities, of course, the Georgia Hospital Association, Hometown Health, which is a rural hospital association. It was co-chaired by Senator David Lucas and Chairman Terry England. And so we spent a great deal of time listening and talking to our rural hospitals. And so we developed the concept, and I say we developed, we actually reinvigorated the concept of the hub and spoke model. Y'all remember that from when we crafted and began to work with critical access hospitals. That was the pretense behind critical access hospitals. And so the hub and spoke is focused on a system of care which we all as patients need. And in this example, we put hospitals at the center and then all the partners that influence and have impact upon that hospital. As we've morphed along and moved through, we quickly realized that perhaps putting the hospital as the hub, while it is a novel idea, the real hub is the patient and making sure that that patient's care is coordinated and centered. However, in our effort, we are focusing on stabilizing of the hospital. Notice in this diagram, we have secondary education for workforce, but also to know who's coming out and going to work in our communities. We have our local boards of education because our school systems are housing many of our most vulnerable patients, our children. You see nursing homes, which again are secondary population that is highly vulnerable, public health, critical access hospitals, physicians, industry, tertiary hospitals, and behavioral health. So we looked at each component, each player, to see what their role was with the hospital and how they could interact, and to make sure that the patients were accessing care appropriately and using the appropriate resource. Next slide, please. This is a map of Georgia just to give you an idea of what we look at. First, notice the high number of counties. Georgia has 159 counties. 109 of those counties are considered rural and hold a population of less than 35,000. The blue represent critical access hospitals and the red represent rural hospitals. I did make a typo on this slide. There's actually 32 rural hospitals and 30 critical access hospitals. So we have a great number. But as you look at this slide, and you can quickly see as the rural hospitals go away, because where you see vacancies of hospitals on the map, about in the center of that is a tertiary facility. So if you look around the fringe of the counties that are not highlighted with a hospital, and you start taking some of those away, you can start to see the big gaps that patients will have to travel to seek care at a hospital. And so it can very easily, when a hospital closes, it can very easily extend that patient's commute time past 30 minutes or 30 miles. Next slide, please. All right. What have been the major challenges for our rural communities? That was the first thing we did as a committee. We started talking about what our challenges are, and we started meeting with our hospitals and having these conversations. And I think it's fair to say that let me pause before I jump into those challenges. Once we developed the hub and spoke model, and we wrote our paper on the integration of care and how we wanted to work with rural communities to help them coordinate care around the region using the hub and spoke, Governor Deal went to the legislature and requested $3 million in state funding to do a pilot project, of which was funded, and 4 were selected. We had 1 way up in North Georgia and 3 along central and southern and eastern Georgia. One thing that is different when you look at Georgia, our demographics are significantly different above Atlanta. There's much less poverty, a much more prevalent, wealthier population in North Georgia than in South Georgia, and health disparities are much more severe south of I-20 or south of Atlanta than in North Georgia. So it's been a great test for us to have these 4 pilots named. So when we had these first pilots named, we began, again, revisiting and talking about challenges. And as they began to expend their grant funds, we began to look at what were their challenges, and they are on the screen here, the primary ones at least. Low volume and lack of community support. And to me, that is the most predominant crisis around rural hospitals. Is we hear and we know that rural hospitals are warranted and needed. However, many people who reside in those communities are driving outside to access care. And that's people who of poverty and people outside of poverty as well. You can tell that with when you look at Medicaid expenditures and your outpatient data, that is very clear that people are mobile, and in particular when you're within 30 miles of another facility. It's a highly competitive market. Physician engagement and willingness to change. We focused, if you look at the last bullet, the right care at the right time and in the right setting. That was our guiding principle for this model. And so part of that means a patient may or may not seek care where they've traditionally done so. We wanted to get primary care out of the emergency room, and we wanted to have it in the physician practice. Well, that's not always possible, either due to hours or due to the availability of appointments. So when we broached that subject with physicians, that was a significant sticking point. Children having access to school. We had one hospital that had dire high rates of children seeking primary care in the emergency room after school hours. And the pediatricians weren't willing to change their hours to accommodate those children. So we put a school clinic in the school that's based with a federally qualified health center, and quickly began to see patients there. And we've seen that model across the country work. We have several clinics in Georgia that work. It is financially viable. We have a couple of pilots that instead of putting a practitioner in the clinic themselves, they deployed telemedicine, which also has been highly effective to evaluate the children. Community education and engagement. Many people residing in communities don't realize the resources that are local. And it's not only for healthcare, but it's for all business sectors. You know, oftentimes people buy groceries out of town. They seek medications at pharmacies out of town. They go for their education out of town. And so there must be community education around local resources and how the hospital can engage that community to utilize those services. There's cultural and lifestyle challenges. Just because care is available, oftentimes we as consumers and patients, we don't practice good behavior. You know, one of the huge issues we struggle with is teenage pregnancy and low birth weight babies. And part of that lies in we don't access prenatal care. We don't practice healthy lifestyle choices with that effort. And so we've got to address that locally. We need to improve our diet. We need to stop drinking, smoking, and doing all the things that many of us think are fun to positively impact our lifestyle and our health. The fifth bullet, timely data. We quickly learned that we're not using data that's readily available to us. What is our out-migration? What are people going out of community for? That's a huge issue that we need to try to reverse. So we need to be able to evaluate our data, change, adapt, reevaluate, and do the cycle again. While that's common for folks that are part of doing regular analysis, so often in work we get consumed with day-to-day operations, and this is especially true in healthcare. And so we don't necessarily look at our data to drive the services that we provide. But the services provided must be data-driven, because the services that are provided must be financially sustainable. Connectivity was an issue in some of our areas of the state. Rural suffers at times with broadband access in our mountainous areas and areas with large tree population makes cellular connections challenging at times. So we need to be able to strengthen that data network, and we also need to be able to share our data. And sometimes the connectivity is a struggle there. In particular, when you're an EMS professional and you're evaluating a patient in the field and you need to transmit data back to the emergency room, having that connection is paramount. And so we've taken great strides in improving that. Last bullet is certainly the hardest obstacle to overcome, which is developing trust among community partners. When we formed these pilots, the first, the second slide that had the hub and spoke there, we asked them to gather those people around and let's talk as a community of healthcare, and how do we ensure that patients are receiving the right care at the right time and in the right setting. However, that may not be my place of business. And when that becomes a service that's not going to be provided in my place of business, can I afford to lose that source of revenue? And that's a huge, huge obstacle. If you start removing all primary care from your emergency department, while you don't have great reimbursement, there is some there. So you need to be able to adapt to the loss of that revenue. The same when we had children seeking care in the school clinic, that reduced the pediatrician's revenue. It was the best option for the children, because one of the things that children face is they at times have caregivers that don't seek out care appropriately and timely, and that is a huge obstacle when you have significant poverty like most of our rural communities do. Next slide, please. This is a snapshot of the current strategies that the four initial pilots targeted. They looked to increase market share, reduce Medicare readmissions, which means get rid of their Medicare readmission penalty as they all had them, reduce non-emergent care and super users in the emergency departments, and increase primary care access, because we know when we increase primary care access, one, it's better for the patient. We also know that the referrals back to the hospital increase. In the second column is the implementation strategy, and there's several for each. The increase of market share, of course, has the largest opportunity. We looked at increasing community and regional presence. We wanted to consume and attract those patients that were out migrating to other areas. We deployed LifePak 15 EKG and advanced STEMI diagnosis and the appropriate routing of the patient. If it was appropriate for the patient to be routed back to the local hospital, we now have an informed medical decision to help guide that patient back to the hospital. And we have seen where this has increased the number of patients that were transported back to the rural hospital. If the patient was more appropriately routed to the tertiary facility, that is certainly the case. But it has been remarkable to see the number of patients that can be retained locally. Stroke center and chest center designations, that's important. Those designations show that the hospital has the capacity and the ability, and it fosters trust among the patients that could consume those resources. Occupational medicine. When you start providing occupational medicine, you're now, one, meeting a need that generates revenue, but more importantly, you're interacting on a regular basis with patients who are insured. And it's important to attract those insured patients back to the local rural hospital. And so developing that relationship, providing them primary care through occupational medicine or injury medicine, that is very important in developing, again, a relationship with an insured patient that may not be using your facility. Level 4 trauma designation, we had one hospital that sought this out to build trust, because once you secure that level 4 trauma designation, while it didn't change a lot, because that's the lowest level of designation, it didn't change a lot of the work that occurred locally, but what it did, it gave them another bragging point, and it gave them another marketing tool to help draw patients in. A very unique project is telenephrology, and we're waiting to see the impact that this program has. We have one rural hospital in our state that provides inpatient nephrology. So Emmanuel Medical Center in Swainsboro adopted the telenephrology project. They knew they could not afford to have a nephrologist on staff locally, so they embraced telemedicine to provide that service. So far to date, over the past couple of quarters, they've seen, I believe, 6 patients, but it's too early to tell on the financial impact. That program is probably the most risky of all, but it does stand to address an immediate need. We know that that community has a high number of patients that are on dialysis, and so they're working in partnership with the State Medical College, which is nearby. It's about 60 miles away, to work with a contractor who's facilitating the connectivity and the protocols and sharing of data. Just one second, if you would. My screen is blank. The next slide, please. All of these things, all of these items that each one of the pilots chose, we established standard performance measures across the pilot. So we had 4 pilots working on different projects, but they had core performance measures. And so I'm just going to briefly go through them because you can read and dig into them independently. And that'll allow us to have more time for conversation at the end. The first measure was to increase revenue. We wanted to meet or exceed net revenue, and we also wanted to decrease charges, because if we decrease charges for our top 25, we knew that, one, we were helping those patients by reducing the care that they received at the hospital. And so that was important to us. We wanted to look at the access to care. We wanted to look at the inappropriate utilization in our emergency department, and we allowed, because it varies by hospital. We had one hospital, if they had chosen 5 visits or more, they would have been targeting over 400 patients, trying to reduce that. So to get them down to a manageable level, they had to go down to 10 visits or more. That gave them about 30 patients to work with. Had they gone to 20 visits or more, they would have only had about 6 patients. So one, they're going to certainly target those 6, but they chose 10 as their cut point, so they had sufficient population to work with to make a meaningful reduction in non-emergent care or overutilization of the emergency department. Next slide, please. The third was readmission reduction. We all know that many rural hospitals struggle with patients on Medicare being readmitted within 30 days, and that's generated a penalty for them, and that's been severely devastating, in particular to many hospitals in Georgia. So that, of course, is a focus. Mental health. You'll notice when we put up the initiatives earlier, it did not talk about mental health. We quickly learned as we got into the projects that mental health was a huge issue in Georgia. It was kind of the elephant in the room that everyone was trying to wrestle with, but nobody knew what to do about it. And so we did establish a mental health measure so that we could start to develop an effort to reduce the number of mental health patients in our emergency departments. And we're looking at the average daily boarding hours. 5, we look at access to care, the potentially preventable hospital stays. 6, we're looking at market share, out-migration, inpatient and outpatient. And number 7, improved fidelity. Looking at HCAHPS, yes, I would definitely recommend the hospital. that perhaps to me is the most meaningful measure. You have a patient that's consumed your resources, they have used your facility, and they left and they said, yes, they would recommend. And unfortunately, we have several hospitals that don't rate real high there. And so that is an area that's getting intense focus. Next slide, please. Before I jump into the rural hospital tax credit, I will say that in the current budget that was started July 1, there was a second $3 million appropriation from the state for us to work with 3 pilots. So we will take another 3 hospitals. We'll take lessons learned for the first set. We will start the second set. We'll identify the projects that they'll work on. They will all have the same set of 7 core measures. But then they may choose other projects that are not the same as the others. We do know that some will be the same, just listening to them. But we were extremely proud and excited for Governor Deal to ask for and receive a second year's of funding. So we will have a total of 7 hospitals that will have concluded this test work. And the beauty behind this project is we have hospitals developing their own solutions. And so as we evaluate their success or failure, we'll be able to make informed decisions about how to share that information and if it's applicable to other rural communities. The next is a new bill to Georgia. It's Senate Bill 258. It's called the Rural Hospital Tax Credit Bill. We had an urban legislator who just wanted to help rural hospitals, and he crafted this idea. It's patterned after a tax credit that supports nonprofit schools in Georgia. Several faith-based and nonprofits have a $50 million pool where people can make charitable donations, and the school is able to draw those funds in instead of them going to the state. The donor receives a tax credit, and so with the hospital tax credit bill, the donor will receive a 70% tax credit in exchange for a donation. So for every dollar donated, they'll get a 70-cent credit. And so in exchange for that donation, the rural hospital, and it's for rural and critical access hospitals, they, 1, must provide more than 10% of their revenue in charity care. They must develop a 5-year viability plan, and there'll be a host of other requirements that they have to meet. Those in specific regulations are being crafted by the Department of Community Health, and Patsy Whaley here at the State Office of Rural Health is working with Commissioner Reese to do that, to help lay those out for the rural hospitals. In year 1, the amount of funding available is $50 million, and that's for 2017. For 2018, it'll increase to $60 million. In 2019, the pool will reach $19 million. In 2020, it will require reauthorization, so hopefully that will occur in 2019. No more than any one hospital can secure donations to benefit them more than $4 million. And so that will create, to make sure that people share the money, and especially for donors who don't necessarily have a preference locally. Some of our large insurance carriers or power companies or those kind of people who might want to donate across the state, those monies could be shared that way. So we're anxiously awaiting the instructions and the specific regulations to govern this, and we're very optimistic that the hospitals will be proactive, and this lets the hospitals be in control. They will now be in control of their destiny because they can do, 1, create viable programs, but then they can also, knowing that they're going to serve a significant indigent population, they can also go out and generate 70 cents on the dollar tax credit revenue for them, which is huge to have that opportunity. Very easily a hospital could have $1 to $2 million within their community. That's coming back, and most of us that live in rural communities that support our hospitals want to donate, and having the opportunity to receive a tax credit is a great benefit for those of us that reside here. Next slide, please. Here you have Patsy Whaley. She's the Executive Director for the Georgia State Office of Rural Health, which is responsible for the rural hospital stabilization work and the pilots. So you have Patsy's contact information as well as mine, and I do work under contract with them. My day job, as you heard, is with Georgia Southern University and the Genting Sioux College of Public Health. So with that, I'll turn it back over to Samantha.
Thank you, Charles, for that presentation. Before I turn it over to Dan, I just want to remind all the participants that you can ask a question at any time during the presentations by entering in your question in the chat box on the bottom left of the screen. And with that, I'll turn it over to Daniel Dirksen to hear about experiences in Arizona.
Hello, everyone. I'm Dan Dirksen. I'm a family physician. I'm the director of the Center for Rural Health here at the University of Arizona in Tucson. Just a quick summary. You've heard from Dr. Pink about the number of rural hospitals closed over the last 10 years and some of the reasons and effects of why those hospitals closed. And you've just heard from Charles about Georgia's revitalized hub and spoke model and in their more than 100 rural counties and creative ways to finance some of that care in these rural areas. What I'd like to share is some of the challenges and, more importantly, some of the pragmatic approaches that Arizona is assuring access to high-quality, cost-efficient health care in rural areas. Just advance this one here. And just a quick summary of the Center for Rural Health, that we do have a mission for over 40 years of improving the health and wellness of rural populations. And like many of you, we have HRSA and CMS funding to help do that. And those are some of the initiatives and programs through the State Office of Rural Health and Rural Hospital Flexibility Program and the Navigator Consortium that we have in-house here at the University of Arizona Center for Rural Health. I like to show this to folks to kind of get a sense, especially for those who live back east, of the size and scope of the area we're covering in Arizona. Our 114,000 square miles would encompass New York, Connecticut, Delaware, Maine, Massachusetts, New Hampshire, Rhode Island, Vermont, and have enough room left over for the District of Columbia. So our rural hospitals are very far away from other things, and unlike Georgia with its many counties, Arizona has very large counties. We only have 15 counties, so much of the care is in these rural and remote areas. You heard from Dr. Pink about some of the rural hospitals. These are just the 75 or 76 now, I think, since just 2010. And I'll just have you try to keep in mind that image as we scroll through some of the other slides. But this is very concerning. It certainly captured the attention of Congress. And this next slide I was asked to speak as an expert witness in front of a Ways and Means Committee in the U.S. Congress, the Subcommittee on Health. And as I was sitting in the airport, my plane was delayed in Phoenix, and I got a phone call from one of our rural hospitals in Douglas, Arizona, which is right on the U.S.-Mexico border, that if things didn't change, they were going to be closing their doors within a week. And I use that as an example once I testified the next day about how critical the health care that's delivered in these rural hospitals is to communities. In that case, unfortunately, the hospital did close. 60 people in the community lost their jobs. And it wasn't just the effect of people losing their jobs and the effect on the economics for that hospital. It had a ripple effect with the nursing home and the pharmacy and probably most importantly, the individuals that now had to travel very long distance to access necessary care. The 24-hour day, 7-day-a-week emergency department was closed, and this created some real issues that the community is still trying to work out. This did receive a lot of interest on the Hill, and I think we're starting to see some of the results of that congressional interest and activity to try to address this crisis situation. One of the things I like to point out also is that right now we're at 31 states that have expanded Medicaid as permitted under the Affordable Care Act. since March of this year, over the 2 years since open enrollment started for states that chose to expand Medicaid, we've had 14.5 million enrollees added to the Medicaid rolls. And in those 31 states in the District of Columbia, we've certainly seen an improvement in the coverage and a reduction in the uncompensated care. And I put this other figure in there about the rural hospital closures. If you kind of look at the concentration of where hospital closures are, there certainly is a correlation with those states that have expanded Medicaid tend to have fewer hospitals to close in rural areas. Those that have not have a higher number. So part of this is within a state's decision-making process about, how do we make sure that the fiscal margins are healthy for rural hospitals and convince our state executive branch and legislatures that expanding Medicaid is one way to make sure that the fiscal margins for rural and remote hospitals remain healthy. Just an example, driving it down to the state level, I mentioned that Medicaid's expanded over the last 2 years by almost 15 million now. People have done what I did for my kids, which is covering our kids on our parents' plan, and about 2 million Americans have taken advantage of that. And then through the federally facilitated and state-based health insurance marketplaces, another almost 13 million have been covered. And the way that plays out in Arizona is that we've added almost 500,000 to our Medicaid program in Arizona. That's the Arizona Healthcare Cost Containment System. That's a 40% increase in enrollment. We've added about 200,000 individuals who have renewed or chosen plans through March of this year. The effectuated enrollment is that number of individuals actually paid their first few months' premiums. That number is always a little bit lower than those who have renewed their plans. They also have to pay their premiums. And then about 70,000 that have covered their kids up to age 26 on the parent's plan. So we've had about 750,000 individuals in Arizona who have benefited from the Affordable Care Act provisions. That's not a direct correlation with the number of decrease in uninsured, but I would say that Arizona in our analysis is about half the number of uninsured, from 1.2 million uninsured to less than 600,000. And far more than any other factor, reducing uncompensated and charity care for our rural hospitals has more of an effect on the fiscal margin and a healthy bottom line for our rural hospitals than any other factor. I'd like to just briefly touch on some of the other factors that we have to deal with. We want to make sure that our rural hospitals have a healthy fiscal margins to carry out these important rural missions. But we also want to make sure that we're improving quality outcomes and enhancing coverage, reducing that uncompensated and charity care, and cost shifting to the rural hospitals and providers. And one of the ways that we do that is making sure that we have enough health providers in those areas and that care is compensated. Some states, such as Oregon and New Mexico, have done things to make sure that those health providers that are practicing in rural areas are rewarded for providing care in these health profession shortage areas. And I really like the model that's happened in Oregon and New Mexico. We're thinking about doing this in Arizona as well, is helping to retain health professionals by providing a tax credit of up to $5,000 per year. This is not only for physicians, but also for dentists and dental providers, behavioral health specialists and such. So this has been very popular in those states that have done it. And for relatively a small investment, the state can help assure that health providers that are most needed in rural areas stay in these health profession shortage areas. One of the things that our legislature did this year that was very important, during the Great Recession, Arizona had frozen its CHIP program, the Children's Health Insurance Program, and the number of enrollees went from 45,000 before that was frozen to less than 1,000 individuals enrolled after that. We were the only state that essentially had eliminated the CHIP program, and that was restored in the last legislative session. And hopefully this will help us get out of this thing of being 49th out of 50 states in the percentage of our uninsured children. We had been in the bottom 5 states for the last 5 years, and we think that about 30,000 kids will be covered, and that'll start in the next 2 weeks. So we're excited about that. That's really a very small investment that yields great results as far as improved health outcomes and access to care. The other thing that I think is important that Arizona did a couple years ago was making sure that for those hospitals to improve the array of services they're able to offer, that they're able to bill and collect for telemedicine services. And so Senate Bill 1353, the Telemedicine Reimbursement Parity Act, was really important to help rural hospitals improve the array of services so that they could keep as much as possible the health care local in the rural community without, losing that care and reimbursement to urban areas. This slide summarizes some of the other issues that help with the financing side of things. There's a critical access hospital pool. It was established way back in 2003 with $1.7 million to 6 of the critical access hospitals. That now has been doubled to almost 12 critical access hospitals, and the funding has gone up to $10.5 million. There's also a rural hospital reimbursement program that includes not just the critical access hospitals, which are those with 25 beds or less and 35 miles or more from another facility, but includes some of the rural hospitals that are up to 50 beds. Of course, we all have heard about the federal subsidy for those hospitals that care for a disproportionate share of Medicare and Medicaid uninsured patients. And while that's diminishing as more people get covered, it was still, in this fiscal year, estimated to be about $162 million for our rural hospitals in Arizona. One that I want to focus on a little bit is Medicaid GME, because I think this is a really important tool for all states that a lot of people don't really understand, but it's really important. In Arizona, about $157 million was paid out to graduate medical education. These are hospitals that have residency programs, and that's reimbursed. And Arizona is the 6th highest state for Medicaid graduate medical education, and yet there is no state general fund dollars that help support that. So, for example, University of Arizona, our teaching hospital here in this urban Tucson area, helps pay the state share to draw down those federal dollars, and other hospitals have taken advantage of that as well. And why is that important? Well, first of all, in the critical access hospital pool, this year we added some things to allow, as you heard about Georgia from Charles, that now we can actually get donations. Political subdivisions, tribal governments, or universities provide voluntary state match contributions, so the state doesn't have to come up with state dollars to support critical access pool funding. We've also done that for Medicaid GME this year. So it allows local, county, tribal government, and public universities to increase federal GME funding by providing additional voluntary state match monies. Now, either through a state plan amendment through the Medicaid program or in the case of Arizona, an 1115 waiver. This year we're asking, and we think we'll get approval, although we haven't heard back yet from CMS, that it'll add another $80 million in support for community-based residency education through our Medicaid GME dollars. This is not a small issue for other states. The data just came out from Tim Henderson. He just released it a few weeks ago. The Medicaid GME funding is about $4.3 billion across the United States. In those states that do it, not all states do it, take advantage of that. It's nowhere near the amount of funding that comes from Medicare GME, but we really feel like this is an important way for states to fund some of the moving the health professions training pipeline to the areas of need, especially in rural areas. And one of the mechanisms allowed in the Affordable Care Act to do that is teaching health centers. There's currently 23 states that do that. Graduates that train in these community-based rural type of teaching health centers are 3 times more likely to practice and stay practicing in rural areas. And so we feel like this is an important tool And one of the sustained financing ways to do it is to start matching some of this Medicaid GME, $4.3 billion a year ago, to help finance these community-based teaching health centers. And this is from a Congressional Research Service report. Unlike for Medicare or other federal GME payment, there is no federal guidance for Medicaid GME. Therefore, states have significant flexibility in designing and administering their Medicaid GME payments. So through a state plan amendment or a Medicare waiver amendment, states can really make sure that they're highlighting and they're emphasizing training that occurs in community-based rural settings. And we think by moving the health professions training pipeline closer to the areas of need, we're much more likely to keep people there. And I finished with this quote, kind of in a bipartisan way. There's no constraints on the human mind, no walls around the human spirit, no barriers to our progress except those we ourselves erect. We're a very conservative state in Arizona, but we've been able to do some of the things to help stabilize the financing for our rural hospitals, move the health professions training pipeline closer to those hospitals to make sure they have an adequate supply of health professionals, and through things like tax credits and being able to create these innovative strategies to finance things, we're not burdening so much our state tax burden to pay the state share of things by distributing that burden to counties and hospitals and others. So we're very excited about it, and I really appreciate the opportunity to discuss some of the things we're doing here. And with that, I'll close and open it up for any questions people might have.
Thank you, Dan, for that presentation. So with that, I think we do have time for a couple of questions here. The first one that I have is for all panelists. Could you identify any of these initiatives that were funded with flex funds, or broadly comment, maybe on the role of flex funds in your state in rural hospital closures?
This is Charles in Georgia. The state office in the flex program, they use the flex funds. One, there's not flex funds directly related to the pilot work, but there is efforts focused on quality for the critical access hospitals, financial and operational improvements, and there is an initiative to help critical access hospitals with EMS coordination of care between the tertiary facility related to STEMI.
And in Arizona, also, we house the State Office of Rural Health and the Rural Hospital Flexibility Program, a small rural hospital improvement program. And as Charles mentioned, that we don't use them directly to match any of these funds, but we do serve an important convening function. We serve important policy informing function of what will happen with various scenarios with policy interventions that happen. What are the fiscal impacts? What are the impacts of on jobs? And what are the impacts on quality outcomes with some of the changes that are being proposed? So we spend a lot of time trying to help policymakers and others understand what options might be available, working with entities like NCSL and National Governors Association and other entities to learn what are the best practices and innovations you've been hearing about in Georgia and Arizona and North Carolina about how we can use data, how we can use information, what new innovation is happening in other states that seems to be working quite well and so in a fiscally responsible and accountable fashion.
Thank you. And our next question is relating to community health workers or other types of providers, and have any of these initiatives incorporated community health workers in engaging some of these super utilizers or in these underserved areas?
Well, this is Dan again from Arizona. One of the things we're working with is the chair of our Health and Human Services Committee is very interested in this issue in the state legislature. The governor's office is interested in this. We're looking at community health workers. We have a long history in Arizona of using community health workers as important providers, especially in our rural and frontier areas. And we're looking at the effects of creating a licensing or an accreditation to allow these providers to bill and collect from various programs, as we did kind of following the path that we did with our telemedicine. So that takes some time. We're probably still a year or two away from being able to do the certification or the accreditation process of that, but it's an important part of our planning.
And this is Charles from Georgia. While we aren't using community health workers in the truest sense, we do have 2 of our rural hospitals that are using EMS professionals under the community paramedic program for care coordination and home site visits. So that is the closest that we have there to a community health worker project. I do think moving forward that we'll see more of that develop, but currently no.
Thank you. And Charles, I do have another follow-up question for you. What has Georgia looked at graduate medical education funding, or what have conversations around that looked like?
Yeah, our Georgia statewide AHEC, which is housed at the Medical College of Georgia at Augusta University, they lead a primary care summit annually, and they consistently have tracked and followed efforts to maximize GME for our state.
Thank you for that. So it looks like we're just about out of time here, so I would like to thank everyone that attended today, and thank you very much to our speakers.
Samantha, could I answer just one other question?
Yes, please go ahead.
Representative Walker wanted to know about Lawrence County, why it wasn't highlighted as a rural hospital. Just wanted to say that the definition for rural is a population of 35,000 or less, and Lawrence always has exceeded that population, so they are considered urban under the Department of Community Health.
Thank you, Charles, for addressing that. I appreciate it. So again, thank you all for attending today. And for more information on rural health, NCSL gathers a number of resources on the topic. So you can visit our website or contact us for more information on the topic. I did want to just notify everyone of an upcoming webinar related to health that we have on healthcare waivers. It's a 2-part series that Cindy Mann will be speaking to. So if you'd like to attend that, you can register on our NCSL website. Again, thank you everyone for attending, and have a good rest of your day.